Well, thank you, Jimmy. I'm glad we were able to get some way to interview our peer specialist. And despite all the different interruptions, I'm going to go on with my talk because I have very interesting information to present. So I'm going to share with you our work in integrating peer support for patients over the past 4 years or so. And this is peer support for patients with substance use disorders, mental health, and co-occurring disorders in our Bartlett Clinic. So while preparing this talk, I really wanted to understand what peers do and what they can add to patient care, what they do that's special. I knew that peer support is common. It's often embedded in alcohol and substance use disorder treatment. So all of us are familiar with 12-step groups for mutual help with peers, like Alcoholics Anonymous, which has been out since the 30s. NA, non-12-step-based groups such as Smart Recovery. We also know in our hospital, peers are embedded in certain areas of substance use treatment, such as a substance use consult service. Oftentimes when patients are referred from the emergency department to the ITU, it's a peer that does a referral. And at the Broadway Center of Addictions, we have peers that work with the patients individually to connect them to supports, as well as co-facilitate groups. However, as I looked at the literature, the idea of peer support in mental health is more recent, starting around the 1980s or so. So I wanted to first go over some of the history of peer support in mental health, which I thought was very interesting. So in researching this, I ran across a familiar name to our department, Clifford Beers. And the history of peer advocacy for mental health reform was kind of the beginnings of our developing peer support for mental health and embedding it into traditional mental health systems. So Clifford Beers was born in 1876 in New Haven, Connecticut. He had 5 siblings, 2 of which passed away from a young age. And the 3 surviving ones also suffered from mental illness, 2 of which tragically committed suicide. He graduated Yale University in 1897 with the hopes of a promising career in business. His symptoms started in 1900 when his favorite brother passed away from epilepsy due to a brain tumor. He then began to worry that he would pass away from the same condition and attempted suicide by jumping out of a 2nd-story window, breaking both of his legs. While recovering in the hospital from his fractures, he began experiencing auditory hallucinations, paranoid delusions, believing that his family was in grave danger. And then over the next 3 years, he was hospitalized in 3 different psychiatric facilities where he witnessed and experienced abusive behavior, particularly by the attendants caring for him, many of whom were poorly qualified, received inadequate supervision by the physicians. Upon his release from these mental institutions, he had a newfound purpose in life, which was mental health reform. To this end, he began writing the book, which became A Mind That Found Itself, which he hoped would have the same impact as Uncle Tom's Cabin had on the abolitionist movement. In 1907, he approached Adolf Meyer with the draft of his book and his ideas for mental health reform. After Meyer read his book, he also began to be drawn to his cause for reform and suggested to Beers the term mental hygiene to use in the development of a national movement, not only to improve conditions in psychiatric hospitals, but it would also focus on education, prevention, supportive activities needed to promote what we call mental health. When Beers' book was published, it received the enthusiastic endorsement of both Meyer and the prominent psychologist William James. It drew widespread public attention when it was published in 1908, both in the US and Great Britain, including the attention of a wealthy philanthropist, Henry Phipps, who within 3 months of the book's publication decided to endow a psychiatric clinic at the Johns Hopkins Hospital with Adolf Meyer as director. Beers also, with the help of Adolf Meyer and William James, went on to found the National Committee of Mental Hygiene in 1909, which is now known as Mental Health America. And the organization focused on mental health advocacy, improvement of services for patients. It now includes training for peer support. And it also focused on prevention, particularly in the early identification of mental health conditions and early intervention in schools and in juvenile offenders. And of course, the opening of the Phipps Clinic in 1913 transformed psychiatry from a primarily administrative and custodial discipline to a legitimate science based on empirical research and taught in an academic setting. And then the other thing is that Clifford Beers is honored on the Points of Light volunteer pathway on the sidewalks of Washington, DC, and there is a plaque dedicated to his memory. He passed away of pneumonia in the 1940s, and then 30 years later, another wave of mental health peer advocate driven movement for reform for mental health began in the 70s. And this was called the Mental Health Consumer Survivor Ex-Patient Movement. And it took its inspiration from the Civil Rights Movement. So with the deinstitutionalization of psychiatry and the closing of state hospitals, patients were being discharged many times without medications or supportive aftercare. They started to meet together for mutual support, began talking about the abuses that they suffered in the state hospitals and being denied basic liberties. One of the leaders of this movement was Judy Chamberlain. In 1966, when she was 21 years old, she became severely depressed after miscarriage. And in her efforts to get treatment, she was misdiagnosed with schizophrenia and involuntarily committed to a state hospital for 5 months. She was treated with Thorazine and other sedatives and told by one psychiatrist she would likely be institutionalized for life. So after she was discharged from this hospitalization, she joined the movement for reform, advocating for the rights and dignity of people with mental illness, something she liked to call mad pride. She ended up publishing a book called On Our Own, Patient-Controlled Alternatives to the Mental Health System, where she described her experiences in the state hospital and consumer-run alternatives, which she felt would be more beneficial for patients or consumers. So out of this came a rise in community-based peer support programs in the 1980s, development of organizations that are still with us, such as drop-in centers, clubhouses, wellness and recovery centers, advocacy groups, and now they've become more incorporated into mental health. They're seen as an adjunct rather than alternatives. So we have local organizations such as Be More Clubhouse, On Our Own of Maryland, which is a lot of peer training and peer support. And then, of course, we know NAMI and DBSA, which in addition to advocacy provides peer-to-peer support and peer groups. In 2003, the President's New Freedom Commission on Mental Health came out during the Bush administration. And this document used recovery in mental health as its major theme. So many of us are familiar with recovery as a concept in substance use and addiction, but the concept of recovery in mental health is also new. And in some ways, this concept of recovery was a way to bring the consumers and professional mental health providers together and find common ground for mental health policy. So there was a shift from an illness-based model based on focusing on symptoms and problems to a recovery-based model focused on strengths and wellness, emphasis on developing recovery support systems and what became now known as the recovery-oriented systems of care. And it was thought that this would address the fragmentation of mental health care, which the report said was in shambles. And that recovery was possible because of advances in mental health treatment. So although some do achieve complete recovery of their symptoms and remission of their symptoms, that even patients with serious mental illness can benefit from a recovery-oriented approach because it expects and facilitates that the person has a good, meaningful life despite their ongoing symptoms, illness, or disability, and that the core engine of recovery is hope, the expectations for better outcomes for both the patient, family, community, and professional, and that peer support, person-centered care, and family community involvement are fundamental to the concept of recovery. So the current SAMHSA definition of, so they call this a working definition, and they developed this with many stakeholders, is a process of change through where individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. And the dimensions are health, the individual being able to take care of themselves and manage symptoms, care for themselves in healthy ways, home, that they have a safe and stable place to live, a sense of purpose, whether it be in employment, academic settings, family caretaking, or creative pursuits, and the community, having meaningful relationships. And then the guiding principles are hope, that's person-driven, it's individual, the person has their own autonomy and choice. There are many pathways, and that recovery pathways aren't necessarily linear, that people can have periods of improvement and periods of relapse. That's holistic, peer support, of course, relational, developing the relations in the community and family. It's culturally sensitive, trauma-informed, so that the patient feels safe and trusted, focuses on the person's strengths as well as the community strengths in being able to offer resources for the person, responsibility not only for the person to take care of themselves, but the responsibility of the community to also offer resources for the patient or the individual. And then respect, so that the community respects the person with a mental or substance use disability, and that they're not discriminated against and accepted. So as you can see, that a lot of these principles do come from the consumer movement, along with input from mental health professionals. And there has been one prominent critic, E. Fuller Torrey, who is a well-known psychiatrist who treats bipolar disorder and schizophrenia, does a lot of research. And his question is where does involuntary or civil commitment fit into this picture, both in the sense of an inpatient or outpatient setting, that it may promote false hope in some patients, and that some patients can only regain their sense of personal choice and be able to enjoy the benefits of recovery if they are in involuntary treatment. But regardless, thinking about some of the patients I see, a lot of them feel like they're defined by their diagnosis. I just had a patient recently who said that, that he has this bipolar disorder, he doesn't wish it on anybody, that keeps him from being a normal person. And I think they can definitely benefit from peer support promoting this recovery model. So with this report, this was one of the driving forces towards integrating peer services into clinical settings. So in 2004, the VA came out with their mental health strategic plan with a call for increase in recovery-oriented services, including funding and expansion of peer support services and peer specialists for veterans with severe mental illness or serious mental illness. In 2010, the Affordable Care Act was based with a shift to team-based healthcare, and peer support began to expand not only in behavioral health settings, but also to primary care and other medical settings as well. There is now a peer certification process for mental health and or substance use disorder in 48 states, including Maryland, which started its process in 2013. And there has been increased funding for peer support. So peer positions funded by the Maryland Behavioral Health Administration increased by 91% from 2017 to 2021. 40 states now have Medicaid reimbursement for peer services in mental health or substance use disorder settings, or both. And in 2022, Maryland was the latest state to join. So peer services by certified peer recovery specialists and community-based substance use disorder treatment programs and opioid treatment centers are now available. So peer providers are known by many different names. They can be peer specialists, recovery support specialist, peer navigator, peer recovery coach, and they're now found in many settings, mental health and substance use disorder settings, but also in mobile crisis teams, crisis stabilization units. So one of the things in terms of the Medicaid reimbursement is they're looking at expanding peer provider support in mobile crisis teams and crisis stabilization, emergency departments, also in primary care and specialty care for chronic medical conditions. So how do we define a peer provider? So this is a term that SAMHSA uses to kind of avoid confusion given all the different roles that peers might play. So a peer provider is a person who uses his or her lived experience of recovery from mental illness and or addiction, plus skills learned in formal training to deliver services in behavioral health settings to promote recovery and resiliency. Core competencies are recovery-oriented, that's person-focused, that's based on a person's own choice and of services and goals, as Alicia said, that is voluntary, focus on the relationship and developing meaningful supportive relationships and trauma-informed. In terms of the Maryland peer credentialing process, the credentialing through Maryland is through a specific board, which is the Maryland Addiction and Behavioral Health Professional Certification Board. So they have 3 certifications for peer workers: certified peer recovery specialist with a family specifier, and a registered peer supervisor. Requirements are that the person is over 18, is a Maryland resident, self-identifies as someone in long-term recovery for at least 2 years, high school graduate, 46 hours of CEUs in advocacy, ethical responsibility, mentoring and education, recovery and wellness, and 25 hours of supervision by a certified peer supervisor, 500 service hours over the past 2 years, and then re-credentialed every 2 years. So as you can imagine, these requirements can vary by state to state. Some do not identify a particular time for recovery, and some don't require the service hours, surprisingly, because they feel that peers may not be able to get those service hours because of their history of disability. And then some require a statewide exam, which Maryland does not. And then in terms of peer support, I wanted to kind of think about what that was, or that is. So one of the early people who started developing peer support training programs was Sherry Mead. And she defines it as a system of giving and receiving help founded on key principles of respect, shared responsibility, and mutual agreement of what is helpful. More specifically for mental health, it involves social emotional support, frequently coupled with instrumental support that is mutually offered or provided by a mental health condition, by others sharing a similar condition to bring about desired social or personal change. And an international organization for peer support training identified the essential elements as just being there for the patient, being there for support when needed, assistance with daily management, whether it's keeping appointments, adherence to medications, diet, exercise, providing the social emotional support, linkage to clinical and community services and providers, and then the ongoing support that they're always there for the person that they're working with. And then I wanted to see how peer support affects behavior change, because that's what, as a psychiatrist, I'm very interested in that, both in addiction and people with addiction and mental health issues. So Gillard in 2015 in the UK looked at 10 peer support programs in mental health settings, 7 of which were community-based and 3 of which were peer support programs in the inpatient setting. And what he found was that the elements of peer support that were really beneficial were the initially just being able to build a trusting relationship based on shared experiences. So peers are more likely to open up to somebody who has actually lived through a mental health experience, gone through the treatment process similar to they have, and that this builds a relationship more easily, facilitates the person being served to be able to open up and communicate more freely and tell the peer provider things that they might not necessarily tell their psychiatrist or therapist. The role modeling is also very important too, because it helps with showing the patient or client that they're able to live a normal life despite their mental illness or substance use issues. And then being able to bridge and engage a person to mental health providers and substance use providers because of this built up trust. That this also results in decreased stigma as well for mental health and substance use disorders. So I want to go on to our what we've been doing in our Johns Hopkins Bartlett specialty practice. And so the Bartlett specialty practice is a HIV and hepatitis C clinic. Originally, it was known as the Moore Clinic, where we treated patients with HIV. I've been working there since residency, so about over 20 years now. And they moved the Bartlett Clinic down to the old emergency department in the, I believe it was Park Building in the hospital. So it provides multidisciplinary on-site services, including specialty care like psychiatry, gynecology, neurology. Also provides medication adherence support with pill boxes, and calls pharmacists calling the patient for refills, pharmacy and lab services. And it's also had Peer Navigator program that's developed over the past 5 years or so. And the Peer Navigators focus specifically on the HIV and getting patients engaged in PrEP, adherence to appointments and medications. So the Bartlett prevalence of person having mental health, at least one mental health or substance use disorder is about 46%. And of course, we know that patients with untreated mental health substance use disorders have decreased access and retention care, poor adherence to HIV treatment, and an increased risk of transmission. So we began our work with, in 2019, so Shoan Filati, who is an infectious disease specialist and an associate professor in the Department of Medicine, approached me. She said she wanted to build on our existing program for buprenorphine in the Moore Clinic, or buprenorphine treatment for patients with opioid use disorder and HIV, and wanted to also include patients with hepatitis C, provide treatment for them. So in our program, a majority of our patients, about 92%, are being treated for opioid use disorder with Suboxone, but we also have about 10 patients on long-acting injectable naltrexone, Vivitrol for alcohol use disorder and opioid use disorder. The other goal we had was to increase training for infectious disease providers to prescribe buprenorphine and get their X waivers, which of course is not an issue anymore. And the number of ID providers we had who had ever prescribed buprenorphine increased tenfold from 3 in January 2019 to 29 in August 2021. And then we wanted to incorporate peer support, because we know that peer supports can engage patients, retain them in treatment, provide the emotional social support, and that they can provide linkage to care for substance use disorder after the treatment for hepatitis C is completed. So we had the peer provider do pretty assertive outreach. In addition to phone calls, they would also sometimes go to the patient's houses for wellness checks. This was prior to the pandemic. And the peer is incorporated as part of our team now, which consists of a nurse practitioner who does the supervision of the peer provider, this initial buprenorphine prescribing, with the expectation that once the patient is stable, that we will transfer them to their infectious disease provider, now that most of them have familiarity with the buprenorphine prescribing process. And then we have weekly team meetings to go over the patients. We were able to get 6-month outcomes on 137 of these patients. And as you can see, 63% of them are male. They were older in age, around 52, predominantly African American. About half had a high school education. 75% were getting HIV care, and 24% for hepatitis care only. And majority were diagnosed with opioid or cocaine use disorder. About half were diagnosed with alcohol use disorder. So in terms of outcomes, what we saw was that there was a decrease not only in opioid use at 6 months, but also use in cocaine and less hazardous alcohol use. And this was by patient self-report. Unfortunately, we weren't able to get urine drug screen results because of the pandemic and the lab being shut down. And we loosened our restrictions about patients needing to leave urine screens before getting their prescription. And then for mental health, HIV, and health outcomes, for anxiety, we had a significant decrease in patients who met cutoff on the GAD-7 for suspected anxiety disorder. But there was a non-significant decrease in suspected depression. And then there was a, in terms of getting test results for patients with HIV and hepatitis C, we were able to get them on about 2/3 of patients. And there were improved outcomes on those measures as well, including 80% of patients who achieved hepatitis C cure. And then also in terms of service utilization, there, for ED visits and hospitalizations for any reason, there was a decrease in 62% decrease in ED visits, as well as a 55% decrease in hospitalization visits. And then in terms of feedback with our peer providers, the patients felt that what was most beneficial was just having somebody there, knowing that somebody cares. So they found the peer support very useful. In terms of the HIV and hepatitis C providers, they felt that there was a reduction of stigma, seeing that the peers were able to function and help patients in the clinic setting, and that their own patients with substance use disorders may be able to function in the same way, and gave them more hope and positivity. So in the next couple minutes, I'm just going to describe our latest project, which is to address people with mental health issues, as well as substance use and co-occurring issues in the Bartlett Clinic. So on a chart review of 153 patients that were seen in the Bartlett Clinic for HIV care, 58% screened positive on the PHQ-2. However, the medical provider only inquired about mental health in a little over half of them, and only a quarter were referred to on-site psychiatry services. The other thing we wanted to look at was the engagement rates. So initial no-show rate for psychiatry intake was high at 48%. And we think a lot of this is due to the stigma of having a diagnosed psychiatric disorder and seeing a psychiatrist or a therapist. So Sean Filati, again, put in and was awarded a R01 grant to, which Jimmy said was a peer support collaborative care for mental health and substance use disorder integrated into HIV care settings. It's a hybrid type 1 effectiveness implementation trial. We're using a collaborative care model, which is a specific type of evidence-based integrated model developed at the University of Washington Department of Psychiatry in the 1990s, looking initially at depression and treatment of depression in primary care. So the way that this model works is that it's focused on patient-centered team care, that it uses a patient registry, so it's population-based, and it uses clinical rating scales which is a measurement-based treatment to a specific target. So for us, we're using the depression, for depression, we're using the PHQ-2, and for anxiety, PHQ-8, and for anxiety, we're using the GAD-7. So the way this model works is that we have the medical provider, here we have the PI shown Filati, who oftentimes has an established relationship with the patient that they're treating for HIV or hepatitis C. We have the peer coach. In the original model, this was a behavioral health manager who is usually a social worker or a therapist. So the peer coach works with the patient, does a GAD-7 and PHQ-8, enters that into the registry. And I meet with the peer coach on a weekly basis. We review the registry where the peer enters patient information in the scales. And I make my treatment recommendations to the medical provider, usually through Epic, based on what the peer tells me about the patient, their progress, and by looking at the scales. So we thought that this model would be, we went with this model because we were concerned about the engagement and being able to reduce stigma, being able to retain patients, but also the collaborative care model is a way to increase screening of patients and to capture those who need mental health care. Often because the patient is not willing to see our on-site psychiatric services, the HIV provider ends up treating the patient themselves, but they're not given effective, timely feedback about the patient's progress and adjustments needed to be made to treatment, specifically medications. So patients will end up being on like 10 milligrams of Prozac for months without any follow-up in how they're dealing with their depression. And then if this model is sustainable, it can fill healthcare gaps in underserved areas. So you've seen a lot of these types of maps in child psychiatry, but it's also true for mental health providers in general. And there are particular shortages in in Maryland, particularly in the western parts and Eastern Shore. So some of our challenges, I think our main challenge was to kind of develop the training for this behavioral or this peer coach model, kind of in being able to avoid peer drift, because peers are not considered clinicians. They use their experiential lived-in experience to help their patients, and that the relationship is more mutual. So they're not the same as, for instance, a social worker or therapist who may have a history of substance use or mental health disorder. Hiring peer providers has been a challenge, finding an appropriate match with our clinic population, able to accept closer supervision than they might be used to, and then kind of thinking about certification issues, whether we want peers to be certified or not. Helping support patients dealing with stress. So Tracy Agee, who's the nurse practitioner directly supervising them, has been great with this. And the peers say that she, oftentimes it feels like she's a peer herself. And then ultimately, while is this going to be a sustainable model of care? We've enrolled about 70 participants so far. We've had some challenges in that 2 of our peer providers left for various reasons, and we're trying to bring on 3 new providers and peers in next month. And hopefully with this iterative process, we're able to better develop, improve, and implement the services that we want to provide for our patients. And then lastly, I want to say thank you to everybody I've worked with, including the research team, the clinical staff at Bartlett, and then also want to give a special thanks to Alicia, who unfortunately wasn't able to make it here. But I think that she gave a very compelling story, which fits in with many of the themes of this talk.
Thank you, Jeff. That was a great talk. I'm so glad we had a steady and unflappable presenter today in the face of technical difficulties.
It was tough, but
yeah, with many intrusions over the loudspeaker, you were the perfect person, kept on going. That was exactly what we needed. Thank you. Really interesting talk and really interesting direction in mental health care. You know, it has a number of potentially a lot of advantages. And I guess one thing I'm thinking about is all the staffing shortages that exist, both here and everywhere. And I guess in theory, one of the big advantages would be if peer specialists were readily available. I think in your last slide, you may have answered my question. It sounds like there may be, you know, I guess you could imagine you'd want someone who is stable and someone who's interested in doing this work and able to maintain it. Are they hard to find?
So they're not hard to find, but I think it's a matter of finding people who can, I think that in our study that peers are expected to do a lot more than they might be doing in community settings. They're expected to learn certain aspects of EPIC, and they're expected to enter information into the registry. So that has been one of the challenges. One of the challenges also is just trying to find kind of the right personality fit, right characteristics of peers that we think would be best for our patients. Ones that would be willing to accept more supervision. A lot of the community peers are more independent in their roles, and a lot of them don't have as much supervision and training in this specific clinic setting.
Yeah. Thanks. Other folks have questions? Dr. DePaula.
Yeah, first of all, I want to say, Jeffrey, thank you. That was a fabulous presentation, despite the interruption. And I thought that seeing the person who had been a patient and now a peer support group was fabulous, really helpful. I would say that since a number of us were involved years ago with the organization that no one really knows about it, which is okay, Drive, we trained 75 different support group leaders for the Baltimore, Washington area. And we did find, and I think this is very relevant to what you're doing, is that they would come and go, okay? And therefore, we would try to train more than you have to have a backup team to support your team, because these are both relapsing conditions, right? Mood disorders and tend to be relapsing. So, and we also found that it was very stressful work. So we had to form a support group for the support group leaders, okay? And we called that postgraduate training. But we might talk, but I think it's a great idea. And the only question I have really is, do we pay them enough to make them want to stay on the job?
So I was going to say that's a major issue. In a 2021 survey of peers in Maryland, they expressed satisfaction in all aspects of their job, except for the pay.
Great. Other questions? Dr. Swartz.
In a collaborative care model, because I always want to see the patient and, so how do you do with that? Do you have the option of seeing patients if you're really worried about them? Do you find that model is fairly comfortable? Just curious. It's not like what we do with supervision with residents, but I always have the option of saying, let's see the patient.
Maybe for folks in Zoom land, I'll repeat the question, which I forgot to do before. Yeah, right. So do you have the option of seeing the patient directly yourself? How do you navigate the collaborative element here?
So that was an aspect that I was worried about myself initially, because when Shona initially submitted the grant, I thought she meant collaborative care in a general sense, but not this specific model. So there is an option for me to see the patient themselves, and also in the collaborative care model that's available. We also have the advantage of being able to refer the patient to our on-site psychiatry services if we're particularly concerned about them. I think the benefit for me is, having worked in the Bartlett Clinic for such a long time, that there are lots, for some of the patients that have been enrolled in the study, they've seen psychiatry before in our service. In the Bartlett Clinic, they just have become not engaged. So there has been a lot of records as well that kind of help me inform treatment and what's going on with the patient.
Thanks. We have time for one last question. I think that was Dr. Franklin who had her hand up. Repeat the question. Is there a career path where people can advance in the peer specialist arena?
I think that's another issue as well. I find that in our hiring process, a lot of the peers want to come to or be hired for our Prosper program because they want some type of career, not necessarily career advancement, but just do something different, because oftentimes their roles aren't very clear when they work in these community settings. But I think that is also a big issue as well. And hopefully with the study, we can kind of come up with the idea of peers doing more if it's successful, because what we are having peers do is a little different than what they're used to in their normal settings, which is can be pretty unstructured sometimes.
Well, that will wrap up. Thanks, Jeff, for this. It's a great project. It's great work. Thanks so much for presenting.
Thanks, everyone.